Now we're going to move on to endocrine. And in general, pathology and physiology, there's a lot of endocrine questions on your test. So we're going to spend a lot of time with physiology and the endocrine system too. So right now we're going to focus on the diseases and what the diseases look like. In physiology, we'll talk more about the hormones involved, okay? All right, so the first thing in terms of endocrine is diabetes, all right? So diabetes, there's type 1, type 2. So let's just describe the patient. So a type 1 diabetic is going to be a kiddo. This used to be called juvenile diabetes. It's going to be a young kiddo who might complain like, oh, my stomach hurts. And then they say kind of these keywords of, I'm thirsty all the time, I'm peeing all the time, or you just notice that in your kiddo. So you go and you check their glucose, and it's like 500. It should be less than 126. So you're like, whoa, this person has diabetes, all right? That is the picture of a diabetic type 1, all right? So if you also look at a type 1 patient, what's interesting is 90% of these patients have an HLA association. So I would be aware of that as well, okay? What we do know about the disease from a pathology standpoint is that these patients have complete beta cell destruction. And what does beta cells do? They release insulin, right? And so insulin is in charge of using our glucose for energy. So if they can't do that, then they start having complications because they're breaking down free fatty acids, they're breaking down proteins, and what happens when that happens? Basically, you have a buildup of acid, and you can get ketoacidosis. Diabetic ketoacidosis happens usually only in type 1 or super severe type 2 patients. But when you hear about it, I want you to be thinking type 1 diabetic patient, all right? The other things that happen with these patients is that they can get microangiopathy, so they get retinopathy, nephropathy, neuropathy. They can also get other ocular issues like cataracts, glaucoma. But the main thing that we need to do for these patients then is to give them insulin, okay? The other type of diabetics is your type 2 diabetics, all right? Type 2 diabetes is not your kiddo diabetes. This is more fluffy grandma diabetes, okay? So fluffy grandma comes into an appointment and she says, I'm feeling fine. She's totally asymptomatic. She's not peeing all the time. She's not thirsty all the time. So she's not giving you those cues. But you go and you check her glucose and maybe it's 200. So not crazy elevated. But her problem here is not that she has beta cell destruction. Her problem here is that fluffy grandma has enough fluff or fat that she can't use her insulin properly. So we call that peripheral resistance, okay? That's the key thing in a type 2 diabetic. Now, I put a graph there that I would definitely know. I put the difference between type 1 and type 2 there so you can see the differences between them. One thing that I think is really interesting is that if you look at genetic predisposition, we tend to think of type 1 as being highly genetic, but if you look, it's actually type 2 that has a strong family history. So I would be aware of that, but just go through that chart there, all right? The other thing I want you to know is the labs, all right? A fasting normal glucose should be less than 126. The other lab that you can do for a diabetic patient is a hemoglobin A1C, all right? And this looks at glucose over how long? Right, 3 months, 90 days. So the other thing that should be is less than 7%, all right? So greater than 7%, greater than 126 fasting, that's when you start worrying about diabetic tendencies, all right? Good. All right, then there's this one called diabetes insipidus, and it's called diabetes insipidus because these patients are thirsty all the time and they're peeing all the time, but you go to check their glucose and it's normal. So it sort of looks like diabetes, but their glucose is normal. This is a different syndrome. This is because of ADH, okay? If you think about physiology, and we'll talk about this in the chapter, ADH, what it does is it goes to the renal tubules and it takes out from the nephron water and puts it back into the bloodstream, all right? If you don't have ADH, or if you have inappropriate syndrome of ADH, which is what this disease is also called, then you don't have ADH going and taking it and putting it back into the tissues. Therefore, you're just peeing all your water out, all right? All right, let's move on to the thyroid gland. There are a lot of questions about the thyroid gland on your test. All right, so let's talk about hypothyroidism first, and let's look at it just from a clinical picture. So this is the patient that comes in, usually females over males, usually comes in and they're just like, I'm tired all the time and I'm getting hairy and I'm gaining weight. I know it's my thyroid. So check this out. Let's look at this visual on what this person's thyroid's doing. So you have your brain, and the brain here is sending down all kinds of thyroid stimulating hormone to the thyroid. The thyroid sort of looks like a bow tie right in the lower part of the neck. So that thyroid then, because of that TSH, starts sending back T4. All right, so the brain is sensing, oh yeah, T4, and it has a feedback mechanism. But when somebody has hypothyroidism, the thyroid gland is barely making any T4. So the brain is saying, come on, and there is a ton of TSH coming. So patients with hypothyroidism have elevated TSH and decreased T4. All right, if you could only order one of these labs, you would order a TSH. All right. So one disease that's kind of specific to hypothyroidism is Hashimoto's thyroiditis. Okay, that's an autoimmune disease that attacks the thyroid gland, and that is the most common form of hypothyroidism in iodine places in the world. So United States, for example, it would be Hashimoto's thyroiditis. Also, patients who get this, again, 40s in that age, and they're female. Okay, let's move on to hyperthyroidism. All right, this patient comes in from a clinical picture. She is just going. Again, females more than males. And you check her out and she's just like, oh, I just have so much energy. And she's like, my hair is falling out, but I don't care because I'm getting real skinny. And she's like losing weight, and she goes, but my heart's palpitating. And she goes, I don't feel good. Well, that's because she has hyperthyroidism. And let's look at this visual to check out what that lab is doing. So we're back here at our good old brain and thyroid. So in this patient, the thyroid thinks it is superthyroid, and now it is sending up all this T4 to the brain. And the brain is saying, whoa, slow down. And so instead, we just have a trickle of TSH, thyroid stimulating hormone, coming back to the thyroid. So here we have a decrease in TSH and an increase in T4. A couple of things I'll just say about hyperthyroidism here is that 85% of hyperthyroidism is caused by Graves' disease. So I would know that too. And again, females more than males, 4th to 5th decade of life. All right. So that is our thyroid gland. Let's talk about the parathyroid hormone. And again, this is really hit hard on your test. So let's talk about hyperparathyroidism. Now your parathyroid glands are 4 lobes that are located right on that bow tie, all right? So 4 parathyroid glands, and of course, parathyroid hormone is released from them. And what does parathyroid hormone do? Right? It increases calcium in the blood, all right? I want you to take a look at this visual, and we're gonna come back to this visual for physiology too. Okay, so when we talk about parathyroid hormone senses how much calcium is in the bloodstream, okay? If you have too much parathyroid hormone, you are going to have too much calcium in the bloodstream. Okay, when that happens, an example of a hyperparathyroidism patient, that patient then will have weak bones, so they can have fractures, they can have kidney stones, constipation, and they are extremely tired. So this patient then, the treatment for this is a parathyroidectomy. Now, let's go the other direction. So what happens if a patient has hypoparathyroidism? Well, let's take another visual and take a look at that. So a patient who has hypoparathyroidism, they have too little PTH, which means they have a decrease of calcium in the bloodstream. When you have a decreased calcium in the bloodstream, you actually have more calcium going to your bones. So symptoms for a hypoparathyroidism patient are tetany, muscle cramps, convulsions, and they can also have changes in their mental status. If you want to tell if a patient has hyper or hypoparathyroidism, the lab you want to do is a serum calcium. We're going to talk about that a lot more when we talk about physiology, and we're going to add in calcitonin. So make sure you watch the physiology video to get a bigger picture on this as well, okay? All right, couple more things before we wrap up endocrine, and that is our diseases of the adrenal gland. Okay, so we're going to talk about Addison's and Cushing's disease. So for Addison's, when you think about Addison's, you need to think of adding more, because what happens here is you have atrophy of the adrenal gland. And when you have atrophy of the adrenal gland, you just don't have as much cortisol as you need, so as much steroid. So you are tired, you have an upset stomach, you just don't feel well. So the treatment here is actually a combination of glucocorticoids and mineralocorticoids, because as we're going to talk about in physiology, remember the adrenal gland is responsible for our sugar, salt, and sex. Does that make you think of that? All right. Then the other one is Cushing's, and this is hypercortisolism, or you have too much steroid on board. So these patients are just like if you would actually give too much steroid to somebody. So they're going to have fat redistribution, they're going to have swelling. They call that central obesity and moon facies, or buzzwords for that. They also can have osteoporosis, so they're going to have bone fractures, hypertension. They also, just like a patient, if you give them too much steroids, are going to have poor wound healing, as well as increased glucose levels, okay? And then the last one is if you have a tumor to the adrenal gland, that's called a pheochromocytoma. And a pheochromocytoma is basically a tumor that's excreting tons of epinephrine and norepinephrine. So this patient is constantly feeling like they're in fight or flight. And you can just go ahead and read that box there below, which tells you the symptoms. I think it's low yield, but you can read through it just so you have a good picture of the disease. Let's move on to renal failure, so our renal system. So the couple things here, we're just gonna kind of hit the highlights. Acute renal failure is any time you are systemically in an abrupt decline and your kidneys cannot produce enough urine, all right? Look at that box there. This is important. I do want you guys to know what labs we look at to determine renal health, and that is GFR, BUN, and creatinine. Now, GFR, we're going to talk a lot in physiology, but that's glomerular filtration rate, and you want it high. So if that is decreased, then we know something's going on in the kidneys. BUN is blood urea nitrogen, and in the text or in the on your boards they might shorten that to just urea or nitrogenous wastes. It's all the same thing. You want it low, but if it's elevated, we think about renal failure. And also creatinine. Everyone's creatinine should be 1.0. If it's higher than that, that means that you have renal insufficiency going on. So be aware of those labs. For chronic renal failure, I just want you to highlight diabetes, and hypertension. Those are by far the main two reasons why we get chronic renal failure, all right? For glomerular disease, there has been a question about nephrotic syndrome in the past. So in terms of knowing the definition between nephritic and nephrotic syndrome, I would know that nephroprotein, if that makes sense or helps you, is a protein wasting syndrome in the urine. So what happens with nephrotic syndrome is that you have protein greater than 3.5 spilling out in the urine. That's what I would know for that, all right? The other things here, I think post-streptococcal glomerulonephritis is really low yield. In terms of pyelonephritis, I would just know that that is a urinary tract infection that has moved up into the kidneys, and you can have inflammation of the kidneys. You have flank pain as well as fever and painful urination. So I would be aware of those things with that. And we're gonna move on. Let's talk about the reproductive system now. And there have been questions in the past for physiology of the hormones as well as the diseases. So I'm going to stick to the diseases here. And in physiology, we'll talk quite a bit about estrogens, progesterones, and those different things with the reproductive system as well. So first thing I would hit on is chlamydia. Now, I would be aware and just highlight this, that chlamydia is the most common bacterial STD in the United States. That I would know for your exam for sure. What is the most common viral STD in the United States? Right, some of you answered herpes, but that's not it. It's HPV, okay, HPV. Remember, herpes, there's a lot of patients who have herpes simplex, but not as many with type 2, all right? So most common bacterial STD is chlamydia. Most common viral STD is HPV. We'll talk about that in a second, all right? Gonorrhea is usually hiding with chlamydia, so we also will check with that too. I would know that chlamydia is caused by Chlamydia trachomatis. I would also know gonorrhea is caused by Neisseria gonorrhea. I would also know that it can be asymptomatic. So some patients are symptomatic, some don't know they have it at all right? In terms of treatment, I would go down to that last bullet point. If you look at treatment, we give patients with chlamydia either azithromycin or doxycycline. You need to add on ceftriaxone, which is Rocephin, 125 milligrams IM to cover both of those diseases, okay? So make sure ceftriaxone, for gonorrhea, as well as doxycycline or erythromycin for chlamydia. All right, a little treatment there. Let's move on. So if you look at the next one, it's herpes simplex virus, which we've already talked a lot about. The only thing I would add in there is that right gram stain. That might be something to know from micro. Otherwise, we've already talked about it, so let's move on. The next is syphilis. Now for syphilis, I would know that it's caused by a spirochete, Treponema pallidum, all right? The next thing I would know is that there are 3 phases. That first phase, that's when you have a canker or a sore somewhere in the boxer short area. And if you get treated at that time with penicillin, you don't complete the other stages. If you don't get treated with penicillin, then you go to the secondary and tertiary stage, which the secondary stage is kind of known for having flu-like symptoms. It can involve the eye, the kidney, the mucous membranes. The tertiary is when you start getting cranial involvement, as well as some of those, it almost looks like a dementia sort of case, all right? So be aware of that. I would not worry about any of the screening tests. I think that's low yield, so I wouldn't even read them. And let's go ahead and move on. Let's talk about the male reproductive system next. Now, BPH is the thing I want you guys to be aware of. Now for BPH, what that is, it's benign prostatic hypertrophy. There are a couple things in men that continue to grow forever. Their noses, their ears, and their prostates, all right? But also we know that growing cells can cause cancer. So we worry about BPH in terms of it turning into prostate cancer. So for BPH, look at the first sentence there, men over the age of 50, highlight that, all right? This is when we start screening them. Signs and symptoms, I would know that. So you have increased urinary frequency, urgency, problems urinating, all can go in there. Treatment, I want you to highlight alpha blockers, such as terazosin, okay? Prostate cancer, then if we go down to that, highlight it's the second most cause of cancer death in males, but it's the number 1 cause of cancer in terms of numbers, all right? We're gonna talk about that more in a minute too. But risk factors, again, age is a big one, positive family history, I would know those. I would also know that third bullet point, which is the lab test. So if you have an elevated PSA, that's when we worry about prostate cancer. Also, in the past, board says wanted you to know this too, so write this off to the side. You can also have an elevation of a serum level of acid phosphatase, so be aware of that as well. The other thing that I want you guys to know is if a patient has prostate cancer, the number 1 place that they're most likely to have metastatic cancer sent to is the bone, all right? So it can be skull, vertebrae, it doesn't matter. I just want you to be thinking mets to bone, okay? Now, let's talk about the female reproductive system. Pregnancy, I don't think you need to worry about that. We're going to talk a lot about the menstrual cycle when we talk about physiology. Let's go ahead and talk about breast cancer though. So breast cancer, just like we talked about prostate cancer, breast cancer is second in terms of cancer deaths in women, but it's number 1 in terms of frequency or how many numbers of patients have it. All right, a couple things I want you guys to know is the risk factors. So if you go just to that paragraph, risk factors, age, okay, family history, and then we also know some things about our BRCA genes. So if they have defects in the BRCA 1 or 2, that's also a risk factor as well. I put a box there and I would look at that. That is just in terms of the number 1 causes of cancers as well as deaths. Look at that so you're aware of where breast cancer and prostate cancer falls into that category. All right. I do want to mention cervical cancer real quickly because we just mentioned that HPV is the number 1 type of viral STD in the United States. And if you look here, that's the cause of cervical cancer. So I would just be aware of that. So now we're going to move on to some kiddo things. We're going to talk about some congenital and neonatal abnormalities. The first one is spina bifida. Okay, I don't need you to know a whole lot about spina bifida except for go to the bottom of that paragraph and you see folic acid. Remember, spina bifida patients, it's because usually they did not get enough folic acid, all right? Okay, congenital heart disease. I don't think you need to know a ton about this, but I would just know the difference between a right to left shunt and a left to right shunt, okay? So if you look at right to left shunt, that means that these kiddos are super sick right away. Because if you think about a right to left shunt, these patients are not going to get their blood up to the pulmonary system to get reperfused and more oxygen. It's going to recirculate. So we think of these kiddos as blue babies because they are really sick and they have really bad vasculature as well. These patients can have tetralogy of Fallot, for example. All right, that also includes right ventricular hypertrophy, things like that make really sick kiddos. The other way is then left to right shunts. And sometimes these kiddos don't even go notice that they have a shunt until later in life because they might have migraines and they might be playing sports and get short of breath. But this is recirculating oxygen, so we don't notice it all the time right away. You might hear a murmur, but it's not causing those cyanotic babies right from birth. So a couple other things we just need to talk about in terms of common congenital disorders. Fetal alcohol syndrome, that's when mamas get too much alcohol during pregnancy. That can lead to congenital malformations. Syphilis, I would know that moms can transmit syphilis to their babies, and we screen for this in pregnancy. And then toxoplasmosis, remember that comes from like kitty poop, kitty droppings. So we tell moms to just stay away from changing kitty litter. Otherwise, that can also result in stillbirth if mama gives that to her baby. That is it for congenital disorders. So let's move on to our GI disorders. The first one is gastroesophageal reflux disease. And basically what happens is you just have stomach contents that tend to come up, causing some what we call as heartburn, and we treat it with medications. So super low yield. Peptic ulcer disease, a couple things I just want to say about this is a lot of patients have it, 20% of the population. The two main causes for peptic ulcer disease is Helicobacter pylori and chronic NSAID use. Because one of the side effects of chronic NSAID use is it's really hard on the gastric mucosa, so you can get an ulcer there, hence peptic ulcer disease. I did put duodenal and gastric, you guys can read through that. The only other thing on this page that I would talk about is Barrett's esophagus. Barrett's esophagus, I would know that it is cancer of the esophagus, and what happens there is it's a metaplasia disease, meaning it changes from one mature cell type to another mature cell type. So in this case, I want you guys to know that normal esophageal lining, so those normal squamous cells, is changed to columnar cells, all right? I would highlight that. That's in the last line there on that first bullet point, okay? Barrett's esophagus then, because it's a changing cell type, can turn into cancer, and it's called esophageal adenocarcinoma. I would highlight that, third bullet point down, okay? All right, if we continue on with the GI tract, then we need to talk a little bit about the colon. The first thing we're going to talk about is just inflammatory bowel disease. And I think the best way to look at this is just by putting it on a chart between the two diseases that it represents. The first one is Crohn's disease, and the other one is ulcerative colitis, okay? So Crohn's disease, ulcerative colitis, couple big differences. I would know for sure that Crohn's disease kind of has skip lesions, so it can happen anywhere in the colon or in the small intestine. Ulcerative colitis has to start in the rectum and move upward. That's the biggest thing I would know. In that box there, I just put the kind of this fun line. It says, for Crohn's, think of a fat old crone skipping down a cobblestone road, because those are all key words in terms of the morphology and the location and the complications of Crohn's disease. So just review that. Okay, colon cancer then is next. Colon cancer, I want you to highlight that first sentence where basically it says it's the third leading cause of cancer and cancer deaths. All right, it's super preventable in terms of having a colonoscopy. Right now, it still states that by the time you're 50 is the time where we start screening patients and they need to have a colonoscopy. What's the other disease that we worry about for colon cancer? Right, Gardner's or familial adenomatous polyposis. Good job. Seems like a long time ago in this video, I'm sure, but you're doing great. All right, let's talk about the liver. Just a couple things. Wilson's is first. Wilson's, just highlight it's a failure of copper to enter the circulation, so you just get a buildup, okay? I want you to highlight, second line down, copper accumulation, all right? The places it tends to go is highlight liver, brain, cornea. That's what I want you guys to know for Wilson's. All right, let's move on to the hepatitises. So remember, hepatitis, itis, inflammation, hepa, liver. So there's a bunch of different hepatitises out. So we need to kind of break them down. First one is going to be alcoholic hepatitis. Alcoholic hepatitis is you get these swollen necrotic liver cells due to too much alcohol intake. This then can cause cirrhosis of the liver, and we'll talk about that later. I also want you to know that anytime we're talking about hepatitis, we look at the liver enzymes, and it's AST and ALT. And these are pretty sensitive. If you take a ton of Tylenol, for example, it can elevate your AST and ALT. So do all of these hepatitises that we're talking about, all right? So the next hepatitis, I would definitely know. I would know A through E in terms of which ones have vaccinations and how you get them, all right? So let's hit it up. So the first one is hepatitis A. Now, hepatitis A does have a vaccination, and usually you get it when you're born and then either 6 to 12 months later, okay? The other thing I would say about it is it's fecal to oral route. And if you want to remember it this way, the vowels go with the bowels. So meaning the vowels A and E, those are fecal oral route, okay? So that's hepatitis A. And yes, remember, it does have a vaccination. Hepatitis B also has a vaccination. This is 3 shots. So right now, kiddos get it when they're born, 1 month later, and then 6 months after their initial one, all right? Again, this infection is going to be spread the same way like AIDS does. So it's through blood, IV drug use, sexual contact, okay? Again, no saliva contact. That does not cause you to have hepatitis B. Hepatitis C now, the rest of these do not have a vaccination. A couple things about hepatitis C I want you to know is that hepatitis C is, if you want to think of the C's going together, chronic, okay? This is the one that's most likely to go to chronic hepatitis, also most likely to have a cancer come out of it, okay? So hepatitis C, all the C's go together. If you look at hepatitis D, oh, and I should say about hepatitis C, again, that's sexual contact, IV drug use, things like that. Hepatitis D, and I want you to know this because I did see this on an old test question. Hepatitis D, the only time it can be there is if you have hepatitis B, all right? D is kind of a wimp. It has to go with B, all right? Make sure you know that. And then hepatitis E, again, no vaccination available, and again, vowels go with the bowels, so make sure that you are aware of that. So those are A through E. I would definitely know those and be familiar with those and get it right on the test. All right, cirrhosis. Cirrhosis is basically when you have bad liver disease, it becomes fibrotic. And when you have this fibrotic creation of this extracellular matrix, things cannot flow through like it should. And so you end up with things like portal hypertension, liver failure, and what I want you to write off to the side is urea, all right? U-R-E-A, urea. When we think about patients who die from bad liver, things like bad liver cirrhosis, hepatitis, they always have this huge buildup of urea, which makes the patient really sick, all right? Good. Jaundice is the last thing then about the liver, and jaundice, go down to kind of almost the end of that, and I want you guys to know that jaundice is the buildup of urobilinogen and urobilinogen and bilirubin in the bloodstream, all right? Your liver should normally conjugate bilirubin and put it into the bile to get excreted, but when that doesn't happen, you can get a buildup, and that's what causes our yellowing of our skin and of our conjunctiva, all right? We see that in cirrhosis, we see that in hemolytic disorders, and also like gallbladder disorders or other obstructive disorders too, okay? And speaking of the gallbladder, that's next. Cholecystitis is the only thing you need to know. Again, itis, chole, it's an inflammation of the gallbladder. I put this bold thing in there. It says most common in overweight females. So we say the fat, fertile female over 40, but I've seen it in a super skinny, healthy 26-year-old too. So it doesn't necessarily mean anything. But I also want you to highlight Murphy sign. Murphy sign is the test. Basically, you just push right over the right side of your abdomen, and then you have the patient take a big breath and let it out. And when you let it out, your hand sinks in, and that causes a lot of pain. Okay? All right, finishing up our GI stuff here, we have pancreatitis. We have acute and chronic pancreatitis. For pancreatitis, I would know the labs, which is amylase and lipase. All right, something's going on with your pancreas. These two will be inflamed. The other thing I want you to know is that when we think of pancreatitis, it can be completely idiopathic, or more commonly, it's because of alcohol use or gallstones. So be aware of that. So we're moving on. We are moving to head and neck disorders. So you guys are doing awesome. Hang in there. This is good stuff. So when we think about head and neck disorders, let's just start with the ears, okay? So for ears, we think about hearing loss. I think you guys can read through that. I think it's low yield. What I would point out is for otitis media, there's two big organisms that usually cause it. The first one is strep pneumoniae, and the next one is H. influenza, okay? H. influenza actually has a vaccination called the HIB vaccination that we can give to kiddos, which is making that one a little bit more obsolete. But in general, we think of something that can treat gram-positive agents in terms of what antibiotic we're going to give them, okay? Vertigo, I would know that vertigo always has a nystagmus with it. I would just highlight that first line. Let's go down to the nasopharynx. I think the nasopharynx, you guys can just read through those. Low yield. Salivary gland, we do need to talk a little bit about the salivary gland tumor, okay? So when you look at that first line, it says 80% of all salivary gland tumors are in the parotid gland, all right? What is the concern about that? What runs through it? The facial nerve, right? So if we have a tumor there that we need to resect, there's always a possibility of damaging the facial nerve. I would be aware of that. In terms of how we get around that, we make sure we scan it well with MRI and CT scans to diagnose the tumor as well as to remove the tumor, which is also the treatment, all right? So there's three types that I think you should know for your boards, okay? The first one is benign mixed tumor, and that's the most common salivary benign tumor, okay? The next one is mucoepidermoid carcinoma. I would know that's the most common salivary malignancy, okay? That is mucus-producing cells. It can be in the parotid gland. It can be on the lower lip of the floor, mouth, tongue, okay? And the last one is the papillary cystadenoma lymphomatosum, or Warthin's tumor. And this is also a benign salivary gland tumor, unknown origin. What I would really know is look at that number 5. It's bilateral, but sometimes you can see the masses at different times in the course of the patient's progression. So be aware of that, highlight that. Also, number 6 is reassuring. It's highly unlikely to become malignant, so be aware of that as well, okay? So sticking in this area, TMJ is next. They're going to talk a lot about TMJ and dental anatomy, so I put very little here. You can read through it, but it'll be talked a lot about later down the road, okay? So we're going to zoom into respiratory system. The first one here is COPD. So when you think about COPD, we kind of throw in this bucket of bronchitis and emphysema, and they're like, yep, COPD. But I want you guys to know the difference between the two, okay? So emphysema, we call those guys the pink puffers, because what happens is because of smoking, and I would know smoking is the main cause of COPD, they have this breakdown in their alveolar walls. When that happens, the surface area they need to mix carbon dioxide and oxygen is very much taken away, and so we hold in oxygen in our lungs. So that's why we call them the pink puffers. If I was going to listen to them, I hear decreased breath sounds. If I was to see them as a patient, sometimes they have what we call this barrel round chest because they have super inflated lungs and it have a puffed out chest appearance. Chronic bronchitis, though, on the other hand, is a little bit different because, again, of smoking, you have this increase in mucus-secreting glands in the lungs, in the bronchi, in the bronchus. And what happens then is because of all that mucus, a patient has a hard time breathing out carbon dioxide. So we call these guys the blue bloaters, all right? If I listen to them, they are wet, they are crackly, they cough a ton, and they look like they don't feel well. They kind of have that hacky, darker skin appearance, okay? So that is the big thing for COPD. So next, let's talk about asthma. So asthma is made up of two components. One, it's acute reversible bronchoconstriction, so highlight that. And the second one is chronic inflammation of the airways. And so these patients often has exasperations. We treat them with bronchodilators as well as steroids. And that is all you need to know. Moving on, if we talk about restrictive lung diseases, so things that a patient can't take big breaths, restrictive lung diseases, we think of things that are environmental exposures. So, for example, occupational inhalation of asbestos would be in there, as well as coal workers' disease, silicosis, berylliosis, all those different things. And chest x-rays of these patients almost have this ground glass appearance or many infiltrates on their lung fields. The next thing that we're going to talk about, continuing on with our lungs, is TB. I would just go through TB. Biggest thing here, I would know that it's caused by highlight Mycobacterium tuberculosis. I would also know that the number one symptom that these patients complain about is night sweats. We think cough, number one complaint and earliest is night sweats, so be aware of that. I also put the drugs there. I don't think you need to know them. So let's go ahead and move on. Other diseases that you just might want to think about when it comes to the lung are bacterial pneumonia, read through that, influenza, read through that. I also want to add in here RSV. So you can either just write that onto the side actually. RSV, which is respiratory syncytial virus. This has been on the test in the past, and I just want you guys to know that that is the most common cause of pneumonia in infants. So be aware of that as well. Moving on with the lung, we're almost ready to wrap it up, but lung cancer we just need to address here. I want you to highlight in that first line, again, lung cancer is still the leading cause of cancer death in men and women. Okay, number leading cause of cancer deaths in men and women. If they would ask just a question like what's overall the number one cause of death, then we'd talk about heart disease, okay? But cancers, it's lung. Highlight adenocarcinoma is the number one kind of cancer in the world. Also, cigarette smoking is the leading cause of lung cancer. Also, off to the side, you've heard of paraneoplastic syndromes. Off to the side, right, paraneoplastic syndrome, that cancer is small cell. It's not in the text. I think it is worth writing off to the side though, all right? Kind of moving on with cancers, we do have two sections left, the next one being neoplasia. So when we talk about cancers, there's a ton of definitions here, and I'm not going to read through each one of them, but I would definitely understand them, and they're also talked about in other chapters. But in terms of classification of neoplasms, I wrote behavior, degree of difference, embryologic origin, gross appearance. Just know what those mean in general. Again, low yield, but be aware of the definitions. For benign tumors, I would definitely know that benign tumors are usually highlight slow growing and well circumcised. Well circumcised means someone can just go in there and cut around it and we're good, okay? A couple different types or words that we use to describe benign tumors are adenomas, cystadenomas, papillomas, and polyps. Okay, those are all, if you see those words, benign tumors. Now, if we move to metastatic, that's a little differently. These are aggressive, highlight that, and they also have invasion to other structures, so they are not well circumcised. That makes them harder to get out as well. Also, a couple different terms there that I want you to know in case those pop on a test. Metastatic is basically a cancer that goes from one place to another. So, for example, from prostate to bone, okay? Metastatic. Carcinoma and sarcoma, we use these interchangeably, but they do mean different things. So when you think about carcinoma, I want you to highlight that it comes from epithelial cells, okay? So like a breast carcinoma, okay? It's epithelial tissue. Versus if you see that word sarcoma, that comes from connective tissue. So like if you have a tumor in a bone, like rhabdomyosarcoma, that is a bone or connective tissue, okay? In terms of moving on to just some more terms, dysplasia I put there. There's different ways that we grade or we talk about cancers. Dysplasia just means organized weird cell growth all the way down to invasive carcinoma. Just read through those, make sure you know those definitions. The next, there's two boxes, and I would think that these are important to know the difference between two, okay? Metaplasia and neoplasia. They're pretty simple, but what it means is metaplasia, if you circle that M, it's a change from one mature, circle that M. Metaplasia is one mature cell type to another mature cell type, like we talked about in Barrett's esophagus, okay? Neoplasia is new, right? That's what neo means, new growth that leads to a neoplasm, all right? So new growth, like if you have a new mole or a melanocytic nevi, those are a very common neoplasm, okay? All right, also I have two paragraphs here about oncogenes and tumor suppressor genes. I would read through those and just remember kind of what they are. Oncogenes is a protein encoding gene that has the potential to cause cancer. Tumor suppressor genes, if you don't have those, again, that can cause cancer. So read through those paragraphs and have a good feeling about what they mean. The last things here in this chapter I think are super low yield. So I want to just read through the malnutrition. I would just skip down to alcoholism. We've talked about cirrhosis. Alcoholic cirrhosis, long-time alcohol abuse can cause cirrhosis. Again, cirrhosis, death can cause, we find buildup of urea. Mental illness and behavioral disorders, I also think that's really low yield. I did put it in there for the sake of completency, but just skim through that and be good. So that is the end of pathology. Again, this is one of those big 5. So you just completed a huge section. So go ahead, do the flashcards, read through the notes again, highlight what we've talked about, make sure you do some quiz questions, and you'll be good to go.